The Congenital Cardiac Catheterization Project on Outcomes, C3PO, is a registry designed by pediatric interventional cardiologists to study risk-adjusted outcomes in congenital cardiac cath lab cases. There are 19 institutions currently included in the C3PO database, and the University of Virginia has been a member of this registry for the past 6 years. While there has been literature published on the incidence of procedural adverse events in congenital cath labs, we are only aware of one other study that looks specifically at anesthesia-related adverse events. We aim to understand more about the role anesthesia plays in adverse events in these cases by looking at sedation and airway-related events at our own institution. Between January 2016 and April 2021, there were a total of 1,281 congenital cardiac cath cases that occurred at UVA and were submitted to the C3PO registry. We ran a data extraction of those cases and found 113 that were documented as having adverse events. We then filtered those 113 cases to find those that may possibly be related to sedation or airway. The resulting 46 cases were then reviewed in detail by our team with input from the interventionist to determine if they were sedation or airway related or not. Using previously established classification system of grading adverse event severity, we only included severe adverse events, which range from, quote, transient changes in condition that may be life-threatening if not treated, end quote, to death. Using that criteria, we found 11 severe adverse events related to sedation or airway. That gives us an incidence of 0.6% of all cases having a severe airway or sedation-related adverse event. 9.7% of all adverse events were severe and related to sedation or airway. This table describes 11 cases where sedation or airway-related adverse events occurred. Interestingly, 10 out of 11 involved hypoxia at some point during the peri-anesthesia period. 7 of 11 were infants with single ventricle physiology. All of them were general anesthetics. Only 1 resulted in death. 5 were interventional cases. 5 were diagnostic caths, and 1 was an endomyocardial biopsy. In the current literature, too little is known about the risks of anesthesia for children who are ASA 3 and up. Even less is known about the specific risks of anesthesia in congenital cardiac patients. One limitation of our study was that there is not an anesthesiologist involved in the initial reporting of adverse events to the C3PO registry. While we just looked at severe events in our study, it is likely that many of the minor, non-life-threatening sedation and airway-related events were never reported to the C3PO database. Moving forward, it would be beneficial to include anesthesiologists in the initial analysis and reporting of these events to such registries. This would ensure accurate reporting of the anesthesia-related adverse events, including the minor ones. This could lead to a better understanding of whether certain factors such as provider expertise, advanced monitoring, or anesthetic technique are associated with the adverse events and allow for a more informed pre-op planning such as staffing, resource availability, and post-op destination.